Now we're going to cover the 4 parts of pharmacokinetics, and part 1 is drug absorption. First, let's start with the definition for drug absorption. It's really the process of entry of the drug into the systemic circulation from the site of administration. Here's how I want you to think about this. Always remember that absorption involves 2 compartments. Absorption implies that I'm going to place the drug into one compartment, and the second compartment is always going to be the blood. I'm watching the drug move from the first compartment into the blood, and that's how I know I'm dealing with the process of absorption. It always has to involve 2 compartments, with the second one being the blood. And that's why you can really miss this point if you're not careful. If I ask you what is the most rapid route of absorption, some people might answer IV. And the reason you would say IV is because you know how fast that route of administration is. The question really is, does IV administration involve absorption? Does IV involve 2 compartments? And you know the answer to that question is no. IV, you're placing the drug directly into the blood. And as a result, it does not involve absorption. That's why you can't answer that question with IV. So what is the most rapid route of absorption? It's inhalation. Inhalation. When you think about all those alveoli, how close they are to capillaries, that's a very rapid route of absorption. There are plenty of other routes that are fairly rapid as well. If you think about the sublingual route, how we take nitroglycerin, that's a very rapid route of absorption as well. Of course, if you take a drug IV, it's 100% bioavailable. It's all in the blood. On the other hand, if I take a drug by some other, what's called an extravascular route, something other than IV, there's a great chance that less than 100% of that drug is going to be bioavailable. Let's define that term. Bioavailability really defines how much of your dose gets into the blood. How much of the dose of your drug makes it into the blood. When I place it into the first compartment, how much of that drug makes it into the blood? By definition, that is bioavailability. When we look at the plasma level curves here, once again, when you see a graph, look at your axes. We're plotting time versus plasma drug concentration. And there are several terms that we want to look at here. First, notice the shape of the curve. Do you notice how we start low? We start basically at 0 as a plasma concentration. We increase over time to a peak, and then we fall away in the process of elimination, all done over time. So you would look at this graph and immediately conclude this must be an extravascular route of administration. In other words, it's not IV, because an IV curve would be shaped totally differently. When I give a drug IV, the graph is going to start up high. I'm going to give a bolus of a drug. I will start up high with my plasma concentration, and that will fall over time in the process of elimination. So the shape for IV totally different from what we see here. In fact, I can imagine that this is an orally administered drug. That's our most common way to take drugs anyway. Let's imagine that. If I take the drug orally, one of the terms that I want you to be able to define is lag time. When I take that drug and I start at time 0, there's a period of time where none of those drug molecules have made it into the plasma yet. So from time 0 until the first molecules show up in the blood, we call that the lag time. Now, just because the drug gets into the plasma does not mean it's working yet. If you follow the curve, plasma levels start to increase, but only when I get to this point defined as the minimum effective concentration is the drug actually going to work in the body. Notice, that's where I first see the pharmacologic effect, the MEC, the minimum effective concentration. So our second term is onset of activity. That's defined from time 0 until I reach the MEC. And the onset of activity does include the lag time because it starts at time 0. Once I've crossed the MEC, in the process of absorption, the drug continues to rise in the plasma. The levels continue to go up until I reach a peak. I reach the peak, and then I begin the process of elimination. And during that process of elimination, plasma levels are going to go down and eventually cross the MEC a second time. So here's our third term. It is duration of action. How about make it simple? Duration of action is the amount of time that the drug is above the MEC, from where I first cross it in the process of absorption to when I cross that number again during the process of elimination. That's the duration of action. Now think about this. Are there ways to manipulate the shape of this curve? Sure there are. I could change the process of absorption. We just covered ionization. Imagine if I did something to change the pH of the stomach. Any of you ever have upset stomachs and take antacids? So what are antacids like Tums and Rolaids? What are those going to do to the pH of the stomach? They're going to increase the pH of the stomach. How does that influence the absorption, let's say, of a weak acid? If it's a weak acid and I've raised the pH of the stomach, isn't it true that the weak acid is going to be less absorbed? So the shape of this curve, the curve is going to be depressed. It's going to shift to the right. It's going to be slower absorption for that weak acid drug because the stomach pH is higher. That means, for example, it's going to take longer to reach the MEC. My onset of activity is going to be increased if I'm taking antacids at the same time as a weak acid drug. But what if I took antacids and then took a weak base drug? With a higher pH in the stomach, the weak base is more likely to be absorbed. So the slope of this curve is going to be steeper. It's going to be increased. So I will reach the onset of activity faster if I'm taking a weak base drug and the stomach pH has been increased. Are there ways that you can change elimination? Sure, you may not want to, but we know that as we age, renal function declines. With declining renal function, for example, you're going to slow down the process of elimination. Which of these terms is that going to influence? Of course, it's going to be duration of action. If it takes longer to eliminate the drug, the duration of action is going to be increased. And that means you're going to have to make a dosage adjustment. If the drug lasts longer, you're going to have to lower the dose in patients with renal dysfunction. The concept of bioavailability. Remember, we've already defined this term by saying that it's the amount of drug, the amount of your dose, that actually makes it into the plasma. What we do to compare bioavailability is we compare the route that we're going to use to giving that drug IV. When I think about the term bioavailability, notice that we use the letter F for bioavailability. It doesn't really make any sense, does it? But if F possibly is standing for fraction, that's the way to remember. F could be the fraction of the dose that reaches the systemic circulation. So what is the F value for an IV drug? Since IV drugs are 100% bioavailable, their F value is 1. But other routes who are going to have a lower bioavailability, their F value is going to be less than 1. So what if I said, well, here's a drug, we give it, and its F value, its bioavailability is 0.8. First thing you know is the drug wasn't given IV. 0.8 tells you that 80% of that drug was bioavailable. And F, bioavailability, is a part of our dosing equations. If you have lower bioavailability, you're going to have to account for that by giving a larger dose compared to, say, what you would give IV. It's not as important to worry about the curve that you see here. The figure that shows you the comparison between an IV dose and, let's say, an oral dose, that's not as important as understanding the concept of bioavailability as it relates to dosing adjustments. The first pass effect has a major influence on bioavailability for orally administered drugs. Remember, the first pass effect refers to the first pass going through the liver. When you take a drug orally, it has to survive the liver in order to make it into the systemic circulation. Let's look at this example. Let's imagine that if you took 100 milligrams of a drug, you swallow that amount, that 100 milligram dose is going to go to the liver. Notice how it's going to get churned around in the liver. And we look and we'll see what comes out on the other side. What amount of that dose made it into the systemic circulation? Was it all of it? As you see in my example, if it was, that would be surprising for an oral drug to have 100% bioavailability. But if it did, its F value would be 1. If I swallowed 100 milligrams and only 80 milligrams made it into the systemic circulation, the F value would be 0.8. 80% would be bioavailable. So clearly the first pass effect through the liver influences orally administered drugs. It's why some drugs can't be taken orally. The example in your book is lidocaine. If I take lidocaine orally, for example, its first pass effect through the liver is going to be so significant, the amount of lidocaine that makes it into the systemic circulation is very, very low. Low enough, in fact, that it's not a useful drug to take oral. So we're going to give this drug IV. Let's take another example. We take nitroglycerin sublingually for an acute angina attack. Give me two advantages of sublingual nitroglycerin. One of those advantages, rapid absorption. You put the drug under your tongue, the mouth is very vascular. The drug is going to quickly move into the systemic circulation, and it's going to bypass the first pass effect. It's going to bypass the liver. So the two advantages are rapid onset and little to no first pass for a sublingually administered drug. The second part of pharmacokinetics, drug distribution. Of course, this involves the process of the drug being distributed throughout the body. The drug has been absorbed, it's in the circulation, it's now going to be distributed to the tissues. Of course, many drugs are bound to plasma proteins. That's a key component of drugs. They're lipid soluble, therefore they need a carrier in the plasma. So many of our drugs are going to bind to plasma proteins. The relationship of a drug binding to a plasma protein is shown on this slide. Notice that when a drug is bound to a plasma protein, it is inactive. So the bound form of the drug is inactive. It has to dissociate from the plasma protein into its free form in order to be active. Now this sets up, though, our first major type of drug interaction. Since most drugs are lipid soluble, that means most drugs are going to bind to plasma proteins. So what if you're taking more than one drug at a time, and those drugs both want to bind to plasma proteins? Well, there's going to be competition. I have two examples to illustrate this point. The first clinical vignette deals with the drug warfarin and sulfonamides. So warfarin is highly protein bound. Somewhere around 98% of the warfarin in the plasma is bound to plasma proteins, leaving only 2% free. Sulfonamides are also highly protein bound. So if you're on warfarin and sulfonamides, there's going to be competition for binding sites on plasma proteins. Most often you think about albumin as the major plasma protein. So let's imagine that for right now. There's competition for binding to albumin. In fact, compared to taking warfarin alone, when you combine warfarin and a sulfonamide, the free levels of warfarin are going to be increased because of the competition. Higher free levels of warfarin can produce a greater chance of warfarin toxicity. So that's the way this scenario would play out in the test question. Patient starts on warfarin. You've been monitoring them for some period of time. You're satisfied with their prothrombin time, for example, but some weeks later, maybe they start on a sulfonamide antibiotic. What's going to happen a little bit later on due to the competition? Higher levels of warfarin in the plasma, increased risk of toxicity. This patient might experience bleeding, bruising, blood in the urine, all signs of warfarin toxicity due to the higher levels of this drug in the plasma. Some of you might also be thinking, well, if the sulfonamide is competing, aren't the levels of the sulfonamide also going to be increased compared to the sulfonamide alone? And that's a good thought. Absolutely, that is correct. But with higher levels of sulfonamides, while there is an increased risk of side effects from that drug, it's just way more likely to see this question in a warfarin scenario where the toxicity is going to manifest as bleeding or bruising. So the side effects tell you what drug was causing the problem. The second example involves sulfonamides again, but this time with unconjugated bilirubin. Remember that unconjugated bilirubin binds to albumin. So here the sulfonamides are competing with unconjugated bilirubin. When the levels of bilirubin go up in the plasma, you get kernicterus and bilirubin encephalopathy in neonates. And this is a side effect of sulfonamides because of their competition for binding to plasma proteins with bilirubin. We sometimes talk about special barriers to distribution. When you think about the placenta, really don't think about this as an effective barrier to drugs, because the fact is that most drugs can cross the placenta. Now, I didn't say that most drugs are teratogenic. I didn't say that most drugs harm the fetus. I just said that most drugs can cross the placental membrane. When I think about this, if I think about a good, effective barrier, that would be the blood-brain barrier. The blood-brain barrier is permeable only to lipid-soluble drugs or very, very small drugs by molecular weight. If I take the examples of lithium and ethanol, lithium is the smallest drug we have, and even though it's positively charged, lithium can get into the CNS. That's because of its low molecular weight. It's so small it can get in. And also ethanol. Ethanol is an alcohol which is water-soluble, but it's small enough that it can actually enter the brain as well. You can follow this rule, that if a drug can cross the blood-brain barrier, it will easily cross the placenta. And occasionally those drugs are going to be harmful to the fetus. They can be teratogenic. If you take my two examples that I just gave you, lithium and ethanol, both of those can harm the fetus. Both have teratogenic effects. What if your job was to design a drug that would be safer in pregnancy? I always use the word safer instead of safe. How could you make a drug safer in pregnancy? Well, you can make that drug water-soluble. If you have a water-soluble drug, it's less likely to get into the placenta and affect the fetus. If the drug was large, size matters. Larger drugs here can effectively cross the placental membrane. What if the drug was protein-bound? That will increase the size of the drug, so if it's protein-bound, it's less likely to affect the fetus as well. In fact, I would love to be able to combine these properties. You can have a larger and a water-soluble drug. You can have a large and also perhaps a protein-bound drug. Notice, however, that water-soluble and protein-bound really don't go together. If a drug is water-soluble, it typically does not need a carrier in the plasma. It doesn't need to bind to plasma proteins. Drugs that bind to plasma proteins are the ones that are lipid-soluble. So it would be unlikely that you could develop a drug with all three properties, but if you had at least two of those, that would be a safer drug in pregnancy. The example in the text of propylthiouracil versus methimazole. The reason why PTU is used more in pregnancy compared to methimazole is it's more highly protein bound. Therefore, it's less likely to affect the fetus. The concept of apparent volume of distribution, abbreviated as V sub D, can be expressed in this equation. Volume of distribution is dose divided by C0, where C0 is the plasma concentration at 0 time, or in other words, it's the initial plasma concentration. This is an equation that you absolutely must know for your Step 1 exam. There aren't a lot of pharmacology calculations that are likely to show up on Step 1. This is one that is likely to show up. The good news is that it's an equation that only has 3 variables, and they're going to have to give you 2 of those variables in order for you to calculate and come up with a correct answer. The variables that they most often give you on the test are volume of distribution and plasma concentration, and you're left to calculate dose. So that again is good news. Volume of distribution is most often expressed in liters, and plasma concentration in milligrams or micrograms per liter. You multiply those two together, the liters cancel out, and you're left with an amount, which would be your dose. So again, if you use your math tricks, you can probably solve this equation pretty quickly. But let's think about it for a moment. What does the equation really tell us? It tells us that volume of distribution and plasma concentration are inversely proportional. Do you see that? They're inversely proportional. So if I give a certain dose of a drug, and most of that dose stays in the plasma, if my C0 is a higher number, that means my volume of distribution is going to be a lower number. So higher levels in the plasma are going to mean a lower volume of distribution. But what if I give a certain dose of a drug, and almost none of that dose stays in the plasma? If the plasma concentration is low, the volume of distribution is going to be high. So understand the relationship. That will help you to predict where is the drug in the body. And with volume of distribution, there are 2 answers. Either most of the drug is in the plasma, in which case you have a low volume of distribution, or most of the drug has gotten out of the plasma and gone to the tissues, and that means you have a higher volume of distribution. Things that are going to keep volume of distribution low are when the drug is highly bound to plasma proteins. If it's highly bound to plasma proteins, the drug stays in the plasma, therefore we have a low volume of distribution. If the drug is sequestered into the tissues, you're going to have a high volume of distribution. We use volume of distribution to calculate our loading dose, which we'll discuss later on. If you'll notice in the margin, we've got a note that talks about normal volumes, plasma volume or blood volume, extracellular fluid, and total body water for a healthy person weighing 70 kilograms. We like to call that person the ideal 70-kilogram man. So if I take a look at those values, maybe this will help you to put into perspective what I've talked about as a low or a high volume of distribution, because some people are uncomfortable with those terms. Here's the way that I think about it. Lower volumes of distribution are those that sound physiologic. The numbers on this slide are all physiologic values. So if I said a drug has a volume of distribution of 5 liters, 10 liters, or 40 liters, all of those could be real physiologic values. On the other hand, I would call those low volumes of distribution if they're physiologic. On the other hand, if I have values like hundreds of liters or thousands of liters, and there are drugs like that. There are drugs that have volumes of distribution of 500 liters, 2,000 liters. If I see hundreds or thousands of liters as the volume of distribution, obviously that's not a physiologic value, and obviously those numbers would be high volumes of distribution. What that really means is that those drugs are easily being sequestered into the tissues. They're probably bound up in the fat, and they're being stored there. That's what those high numbers are telling us. So if they're non-physiologic, those are our larger, higher volumes of distribution. When I look at my equation, volume of distribution is dose divided by C0. I need volume of distribution to be expressed as liters, though sometimes I see it expressed in a question as liters per kilogram. Here's a very important note for you. If I ever see volume of distribution expressed as liters per kilogram, there's no place for kilograms in my equation. The first thing that I want to do is multiply by the patient's weight. Find their weight in the question, multiply times the volume of distribution so that I can cancel out the kilograms. That leaves me with liters, which I then plug into my equation. The concept of redistribution basically says the drug has been distributed throughout the body, and now it's going to be redistributed. Probably the best example of this is the IV anesthetic thiopental. When you give thiopental IV, it's going to rapidly reach the brain. In less than a minute, you're going to start to see some effects from this drug. So it has a very rapid onset. But what most people don't remember about this drug is it actually has a relatively long half-life. Thiopental has a half-life of 9 hours. It doesn't last that long as an anesthetic, so what am I really saying? I'm saying the drug rapidly goes into the CNS, but then it gets redistributed. So where is a very lipid-soluble drug like thiopental going to go? Those very lipid-soluble drugs are going to redistribute to the fat. So thiopental has a longer half-life because it's being sequestered in the fat, but that's not the same as saying that the drug is going to work for 9 hours. When it's redistributed, you end up terminating the action of this drug. Redistribution is illustrated in this figure. So if I administer a drug, and let's say that that drug is thiopental, that's our example, the drug is going to go more rapidly into the CNS compared to the fat, even on initial distribution. Can you explain why? Why does that drug move more rapidly into the CNS initially compared to the fat? Well, this goes back to an earlier concept on vascularity. Who's the more vascular tissue? Is it the CNS or the fat? Obviously, it's the CNS. With greater blood flow, the CNS is going to get a higher concentration of the drug initially on initial distribution. So the drug moves into the CNS. It will then move back out of the CNS and be able to move into the fat. It can sequester into the fat. and its movement into the fat is going to occur basically down its concentration gradient. But what if I gave a second dose of thiopental? Assuming I've already given one dose of thiopental, when I give a second dose, the second dose is going to rapidly move into the CNS, again, greater blood flow. But when the drug goes to move into the fat with the second dose, the movement into the fat is even slower than it was the first time. Now, why is that? Obviously, it's because there is already some drug in the fat. I've changed the concentration gradient. With the second dose, the movement is even slower because I've got less of a difference there in the amount of drug in the blood compared to the fat. And keep going. What if you gave a third dose? Now the movement is even slower into the fat because of the accumulation. The storage of the drug in the fat has changed your concentration gradient. And if you're moving even slower into the fat, that means the drug will last longer in the blood and potentially means it goes back into the CNS, and you can prolong the effects of thiopental because you're saturating its storage site.